Shock is defined as a state in which tissue perfusion is inadequate to maintain normal aerobic cellular metabolism. Shock has been divided into 4 or 5 different types according to its etiology: hypovolemic, cardiogenic, septic, neurogenic, and hypoadrenal. Hypovolemic shock. Hypovolemic shock is defined as tissue hypoperfusion resulting from inadequate intravascular volume. This is the most common type of shock that is encountered in surgical patients. The most common cause of hypovolemic shock is hemorrhage. Hemorrhage can occur post-operatively or after a trauma. Not uncommonly, patients with a GI bleed can present with significant blood loss as well. Surgical patients that are not hemorrhaging can develop hypovolemic shock. The third spacing that occurs in inflammatory conditions, such as a moderate or severe acute pancreatitis, can cause hypovolemia. Unrecognized GI losses from nasogastric tubes, ostomies, emesis, or diarrhea can also cause significant hypovolemia. Hypovolemic shock is diagnosed with a combination of a history consistent with one of the listed etiologies and the clinical signs seen in the majority of patients diagnosed with shock: hypotension, tachycardia, agitation or altered mental status, oliguria, pallor, and cool, clammy skin. The treatment of hypovolemic shock begins with ensuring the patient has an adequate airway and is ventilating appropriately. For some patients, this may entail intubation. Next, volume losses need to be replaced. Blood volume with blood products, packed red blood cells, fresh frozen plasma, and platelets. Total body water with crystalloid. Any ongoing losses need to be addressed and the etiology corrected. Hemorrhage has been further stratified into classes. Class 1 hemorrhage occurs when there is a loss of 10 to 15% of the circulating blood volume. In a 70-kilogram male, this would be between 500 and 700 milliliters. For perspective, when a person donates blood, typically 500 milliliters of blood is removed. This amount of blood loss is typically well tolerated and no change in blood pressure is usually seen. Class 2 hemorrhage is a loss of 20 to 30% of blood volume, 750 to 1500 milliliters in the 70-kilogram male. These patients will have mild tachycardia and narrow pulse pressure, delayed capillary refill, tachypnea, and at times mild to moderate anxiety. Class 3 hemorrhage is a loss of 30 to 40% of blood volume. In the 70-kilogram man, 1500 to 2000 milliliters. These patients will have hypotension, marked tachycardia, confusion, pallor, and oliguria. Note that in order to have hypotension with hemorrhage, 30% of the circulating blood volume has been lost. Class 4 hemorrhage is a loss of more than 40% blood volume, greater than 2 liters in our 70-kilogram person. These patients will have hemodynamic instability, significant mental status changes. Class 4 hemorrhage will result in cardiovascular collapse if it is not promptly treated. Cardiogenic shock. Cardiogenic shock is defined by circulatory failure despite adequate intravascular volume. The causes of cardiogenic shock can be divided into 2 categories: intrinsic and extrinsic. Intrinsic causes are a result of malfunction of the heart itself, as with malignant dysrhythmias or large myocardial infarction. Extrinsic causes result in pump failure by creating an obstruction to normal flow. Cardiac tamponade prevents adequate filling, as does tension pneumothorax. Tension pneumothorax can also cause kinking of the vena cava from mediastinal shift. Massive pulmonary embolus obstructs the cardiac outflow. Higher pressures and positive pressure ventilation can also diminish cardiac preload, causing diminished output and, if unrecognized, eventually shock. The diagnosis of cardiogenic shock can at times be difficult. It is not uncommon to see it combined with other types of shock, example, an elderly trauma patient. A pertinent history in a hypoperfusing patient combined with some of these signs on physical examination will lead you to the diagnosis. An S3 gallop, basilar rales, new cardiac murmur, muffled heart tones, JVD, tracheal deviation, or unilateral absence of breath sounds are suggestive of cardiogenic causes for the hypoperfusion. 12-lead EKG, chest X-ray, and/or echocardiogram can be diagnostic. For suspected PE, CT angio of the chest is diagnostic. The treatment of cardiogenic shock begins with ensuring adequate airway and ventilation. IV fluid should be administered judiciously. The treatment is dependent on the etiology. Inattention pneumothorax, an expeditiously placed chest tube, is a life-saving procedure. Pericardial tamponade may be treated by pericardiocentesis, pericardial window, or thoracotomy depending on the cause of the effusion. Pulmonary embolus can be treated with catheter-directed or systemic anticoagulation. In unstable patients with massive PE, embolectomy, endovascular versus surgical is therapeutic. Patients with intrinsic cardiogenic shock need to have their electrolyte imbalances corrected and any dysrhythmias addressed. Antiarrhythmic agents, cardioversion, and/or pacing may be used as needed. In ischemic patients, their need needs to be addressed, and as needed, inotropic support may be added. Prompt revascularization may be needed, so the patients should be treated in conjunction with the cardiologist. Septic shock. Septic shock is defined as tissue hypoperfusion that occurs in the presence of a systemic inflammatory response to infection. The etiology is overwhelming invasive infection. In order to make the diagnosis of septic shock, the patient needs to exhibit three general characteristics: systemic signs of inflammation, documented infection, and tissue hypoperfusion. On physical examination, the signs frequently seen that differ from other types of shock are warm skin and a hyperdynamic picture. If one were to place a PA catheter, the patient with septic shock is seen to have increased cardiac output with a hypotension. The tachycardia, oliguria, and mental status changes seen with other types of shock are also seen. As with other types of shock, the treatment of septic shock begins by ensuring the patient has an adequate airway and is ventilating appropriately. The patient should be volume resuscitated. Empiric antibiotics to cover the most likely organisms should be initiated. The source of the infection should be treated. If there is a line sepsis, the infected line needs to be removed. If there is an intra-abdominal source, it should be addressed. Vasopressor support may be needed. Neurogenic shock. Neurogenic shock is defined as tissue hypoperfusion that occurs as nervous system failure causes decreased peripheral vasomotor tone. The etiology is acute spinal cord injury. The disruption of peripheral vascular regulation occurs as the injury prevents the vasoconstrictor impulses from reaching the peripheral arterial bed. This results in an increased capacitance causing decreased venous return. The end result is decreased cardiac output. The diagnosis of neurogenic shock must be one of exclusion. Spinal injuries typically occur with other traumatic injuries, and it is very important to rule out hemorrhage as the cause of the hypoperfusion. On physical examination, in addition to the signs typically seen in other types of shock, the patients are generally warm and will demonstrate a neurologic deficit. If the spinal injury is above the level of T4, an inappropriate bradycardia will be notable. After addressing the patient's airway and ventilation, these patients need aggressive resuscitation. Large amounts of crystalloid may be needed to fully compensate for the increased capacitance. Despite aggressive fluid administration, many of these patients will need vasopressor support. Dopamine and/or alpha agonists such as phenylephrine may be used.